Hello and welcome to the Brain Matters podcast, brought to you by the Florey Institute, Australia's largest brain research centre. I'm your host, Dr. Shane Huntington, and together we'll be exploring the fascinating world of brain health. We'll meet leading doctors and researchers and learn about the reality of a range of brain and mental health conditions from people with lived experience and their carers. In this episode, we'll be exploring neuroimaging. Our ability to capture images of the brain has progressed significantly over the last decade. Not only can we see with higher resolution than ever before, but we can also monitor brain activity in real time. Brain imaging is starting to move well beyond being a diagnostic tool. In this episode, we'll explore some of the new treatments for brain disease that utilise imaging systems and what we can expect in the decades to come. Joining me today to discuss this important area will be Austin health neurologist Dr. David Vaughan. David is a clinical researcher at the Florey and has a special interest in using magnetic resonance imaging to target sites in the brain for surgery for epilepsy. Welcome, David.
Thanks, Shane.
We also have Associate Professor Heath Pardoe. Heath leads the Florey's neuroimaging theme and is interested in how MRI can measure brain health and how it can help Australians live long and healthy lives. Welcome, Heath.
Thank you, Shane. Good to be here.
And we'll also be speaking to epilepsy patient Amber Starlight, who has a truly remarkable story to share about how brushing her teeth while undergoing an MRI has changed her life. Welcome, Amber.
Hey, how's it going?
It's great to have you here. Heath, I'm going to start with you because I think the emphasis here is we have two physicists in the room, which is very rare for one of these podcasts. So we need to talk about the essence of what MRI is. But first of all, what got you into science? You have an interesting story there around Halley's Comet.
Sure. So back in 1986, I was a young lad living out in the countryside in Western Australia, and Halley's Comet entered, within proximity of the Earth. And so because of where we were positioned, it was quite easy to see Halley's Comet from the ground, and particularly with a pair of binoculars. Mm. So around that time, we had our, school science projects. I chose Halley's Comet as a project. And just that whole process of synthesizing information about Halley's Comet, the fact that it was a natural phenomena that I experienced, I just really enjoyed that process. And that also included, panicking in the 3 days before the project was due and getting that real jolt of adrenaline when I was trying to pull everything together. And that's once I'd pulled that sort of project together, I thought, this is pretty cool. Yeah. I'm going to keep doing science.
Amazing. Amber, for you need to be around in about 30, 35 years. I think we may not see it again. You will definitely get to see this amazing piece of science. So exciting.
Nice.
Now, Heath, let's talk about imaging, because this is something that I think many of our listeners will have experienced or had family members who have experienced various types of imaging. But I think it's good for us just to break down some of the differences. So if I throw three particular types at you, maybe you can sort of talk us through a bit about how they work and how they differ. So ultrasound, CT scanning or X-ray scanning, and MRI. How do you sort of distinguish them?
Okay, sure. So they vary basically by the mechanism by which a signal is generated. And so ultrasound, as you could guess from the name, means that sound is the source of energy that is used to generate an image. And the name ultra means that it's at a high frequency, so it's at a higher pitch than what we can normally hear. The reason it's at that pitch is because that's a very good frequency to get biological information from the organ that you're putting the sound energy into. The second one, CT, is that correct?
Yeah, so X-rays.
X-rays, yes. So that involves exposure to ionizing radiation. And what that really means are that very small particles are passing through the organ of interest or the body region that's being imaged. And the particles don't pass through structures like bone, but they do pass through soft tissue structures like muscle or fat. And then you have, in the old days, it used to be a film on the other side of the detector, and essentially you would see regions where the particles did pass through expose the film, and then regions where the particles were stopped, the film was less exposed. And there's an equivalent to that with digital detectors now. So it's exposure to ionizing radiation for CT scans and X-rays.
Which I suppose a little bit of is okay when the health benefits are warranted.
Absolutely.
But I don't want to get a CT scan, which is many hundreds of X-rays at a time, multiple, 10 times a year.
Absolutely. There is a limit. But, technology is even evolving in that space, which generally involves minimising the amount of ionising radiation that you're exposed to.
So then we come to MRI, the exciting stuff for today.
Absolutely. And that's what both David and I specialise in. With MRI scanning, you're exposed to electromagnetic radiation. It's at a different frequency to something like a microwave, but it's relatively close in the electromagnetic spectrum to microwave frequencies. So the reason people may know with an MRI scan, you're placed inside a very long tube, and the reason you're inside the tube is that you are inside a strong homogeneous magnetic field. So the combination of the electromagnetic energy that's put in and the fact that you're in a strong magnetic field means that you can generate a signal from water molecules in your body, or protons.
Yep.
And then there are some tricks that are used to generate an image, but essentially the source of the signal for MRI scanning are water molecules in your body.
Right. So, and this is where it becomes particularly of interest because of the soft tissue elements, whereas X-rays are a lot harder to, and ultrasound, the resolution is very poor. Mm-hmm. X-rays are not great with soft tissues, but with an MRI, essentially anywhere where we have fatty tissue or watery tissue of any type, the MRI can do its job.
Correct, yeah. So the water molecules or the protons are very sensitive to the environment that they're in, and that environment varies depending on different regions of the brain or between fat and muscle tissue. And so MRIs, as you said, are very good for generating contrast between those tissues. So if you take an X-ray of a brain, it's relatively difficult to discriminate different structures within the brain. But if you take an MRI scan, you see this really beautiful anatomical detail between different brain structures. And that's because the protons are sensitive to the environment that they're in. Yeah,
it's fascinating. I think the idea of a strong magnet aligning all the or enough of the protons in our body, because they're all little magnets, right? So
Correct.
It's a whole lot of little magnets. Big magnet makes them all point in the one direction. Mm-hmm. We hit them with radio frequency or essentially a form of light, a form of electromagnetic radiation, and we whack them off kilter. So they're no longer aligned. Then we turn that signal off, and all those little magnets want to get back to where they were. Yeah. And how quickly they do that tells us where they are.
That's a perfect explanation.
Which is quite fascinating. Right. And we have to detect, the radio waves go in. As they move back to where they were, radio waves get spat out, and the system detects those. And then somehow there's some complicated magic that allows us to redesign or pull out of that the design of the body.
That's right.
Phenomenal. Yeah. So, David, from your perspective, when you're looking at the brain, what are you trying to see with an MRI? I mean, you can see all these soft tissues, you can see variations in their density and so forth. I mean, what do you want to see?
Just the fact that we've got MRIs are amazing, and it's really only in our generation's lifetime that we've had the ability to do this. Only 70 or 100 years ago, if you wanted to know what was going on inside the brain, you had to cut it open and have a look. So whenever I look at these amazingly high-res pictures of inside the brain that Heath and the team are able to generate, I'm always amazed. So I work with people with epilepsy, and the thing that really matters for someone with epilepsy, and especially when seizures are happening and not stopping with medications, is why is it happening, and what part of the brain is driving the seizures, where are the seizures coming from. There's lots of different causes for epilepsy, but really any change in the shape of the brain, any scar in the brain can be the place where a seizure starts. So what we're looking for on an MRI scan is any tumour or scar, and one of the particular things we're interested in is ways that the brain is formed when it first folded. One of the common causes of epilepsy is a cortical malformation, which is where the cells that were meant to go and form the layers of the brain on the outside folds, they're meant to travel there and then get there and then hook up with all their neighbours in the right way. Sometimes some cells don't go to the right place, and a group of them form grow in a pattern that's not quite right, and that happens when the brain's growing. But then later in someone's life, maybe as a child or a teenager or an adult, they might have seizures that start happening. And if we can spot those group of cells or that malformation that's happened, or any other cause like a stroke or a tumour, then we've got an explanation of why it's happening and something that we can potentially target.
Right, yeah. It's interesting to me, like when you talk about that, because I think I always perceive the brain as this incredibly complex structure, and I realize it is to an extent, but when you describe it like that, it sounds almost simplistic in terms of where these errors can be. I mean, is that right, or is the complexity, part of the problem here is that and the MRI gives you an insight into that? Like with these errors, are we talking about like what seem like really obvious structural errors, or is it far more complicated and harder to see?
They can be medium size on a scale of a few centimetres, or they can be tiny on a scale of millimetres. So the structure of the brain is complicated. There's all the folds on the outer surface, and then beneath that there's all the wiring, the axons that link everything together. And then deep in the core of the brain there's some hubs of clusters of cells that kind of connect everything together and are involved in coordinating and linking everything. So it's a complicated structure, and the lesions that can cause epilepsy and make things go wrong can be tiny. It's a bit like finding the right address in Australia. Sometimes we know it's in the frontal lobe, maybe it's like, it's in Victoria, but then pinpointing it down to a small group of cells, sometimes a few millimetres in size, which is what we really want to be able to do, that can be a real challenge. And so that's why we need these really high-res pictures to be able to zoom right in to find it.
Interesting. Now, Heath, MRIs have changed a lot. In fact, I have a vague recollection that they used to be called nuclear magnetic resonance imaging machines.
Correct, yeah.
But no one wants to put their head in something with the word nuclear on the front. So I get that. But, I mean, first of all, there is no ill effects on the body. This is not like an X-ray. There's no ionizing radiation. So it's perfectly safe to have an MRI. I mean, unless you've got a whole lot of metal in your body and you need to take that out. But in terms of the resolution, when David's speaking about that, how much has that changed over the years?
It's certainly improved. So, David was just showing me some images on a project that he's working on that have a resolution of 400 microns in plane. That's correct, isn't it? When I started my career about 20 years ago, the sort of scans we're requiring had maybe a 2 millimetre resolution. So it's increased. I'm a physicist, so I'm not too good at maths. Increased tenfold, let's say. Yep. Yeah, so the resolution's improved, but one of the really the main things that's improved, which is as important as, resolution, that is the size of structures that we can image, is improving the contrast between different structures. And, when you go and get an MRI scan, typically you'll get what are known as a couple of different sequences, each different series of images which highlight different aspects of our anatomy. And that's really something that's changed a lot over my career as a researcher. There's a much bigger choice of sequences to use which can highlight specific areas of the brain or highlight areas of damage. Some sequences might highlight the grey matter in the brain. Some might be used to measure the vasculature. So it's really contrast mechanisms and spatial resolution that have improved a lot over the time that I've been a researcher.
Yeah, I think it's interesting when we talk about that spatial resolution of 400 microns. So in context, the human hair is about 50 to 80 microns wide, but this is done at a distance. There's nothing touching your head. This is a scan of the distance of the interior of your brain, which is quite phenomenal when we think about that aspect of it.
Absolutely. Compared to, histology where you're looking at something under a light microscope, you need to slice it up into a section to image it. In the case of MRI scanning, it's non-invasive, so there's no cutting the head open.
Thankfully. Which brings me to you, Amber.
Yeah.
Obviously, the head being cut open for the MRI scan. Now, tell us about your story, because you've had epilepsy since presumably when you were fairly young.
Yeah. So I started having seizures when I was about 14 years old. I didn't get diagnosed with epilepsy until I was about 18. And my seizures were quite resistant to treatment. Like, I'd been on so many different types of medication and really high doses, which is not ideal when you're a teenager.
And what did your seizures look like?
They were in the top of my body, in my mouth, and sort of the right side of my shoulder, where my jaw would sort of seize up, and I would be having difficulty breathing. I would also fall over, I guess.
So life-altering, though.
Yeah. Like, I was having these every day. Like, especially at night, I was having, like, multiple seizures per night.
So every night?
Every
day?
single night, yeah.
Right, okay. And the medications weren't reducing the frequency?
No.
Presumably some side effects?
Yeah, mostly, like, I think they helped in the sense that they were, like, just slowing my brain down. So I was having fairly, like, a few less seizures, but I was also exhausted and my brain function was really struggling.
Right. And David here said, there's other options.
Yeah, thank God.
And but this involves surgery for you. So this is this must have been a pretty scary prospect, the idea of someone cutting into your brain.
Yeah, well, because surgery initially came up about a year after my diagnosis. So I was 19 years old. And initially the surgery that would have been required would involve cutting my brain open, going in, scooping it out. Pretty terrifying stuff. Luckily enough, in the time period that I was on the wait list for surgery, they, like, developed a new one that was way less invasive. Like, I don't even have really any scars from my surgery. They went in with tiny little metal rods, like maybe a millimeter thick, into my brain, and they used that to basically, like, laser it out. I don't know. I don't have any of the technical terms. I've really forgotten most of this.
Yeah. Of course, they needed to know where to go. So, and this is a part of your story which I find fascinating. So talk us through how that worked, like how they worked out what part of your brain they had to address.
Okay, so my seizures were brought on by, like, various things such as, like, if I wasn't breathing enough, like, so exercise would bring it on, if it was too hot, if I was too stressed. But one of the things that would reliably bring on a seizure was triggering the muscles in the back of my jaw, the ones that would generally seize up. So I would have a seizure every single time I brushed my teeth.
Well,
which is quite inconvenient because you kind of need to do that twice a day.
Yep.
So I'm like, oh, here's my 9 o'clock seizure.
Right.
So the way that we were able to, well, not we, I didn't do anything, I was in the MRI machine, but the way that they were able to pinpoint where my epilepsy was I had an MRI scan where I brushed my teeth in the MRI to, like, try to trigger a seizure while in the MRI.
That's wild stuff.
It was crazy.
And, like, when I think of MRIs, and David, you can sort of correct how this works for me, but, the one thing, I've had a couple, and they always say, stay still.
Yeah.
How does this work for Amber where she's brushing her teeth in the MRI? I can't stay still when I'm brushing my teeth.
Yeah, well, that's exactly right. Like taking any picture, staying still is really important. So we wanted to map where in Amber's brain was being activated when she was brushing her teeth. Because our theory was that, when she brushes her teeth, a bit of her brain's getting activated either by the movement or by the sensation. And it's the activation in that group of cells that's setting off the seizure. So that was our theory. If we could map where it's being activated with brushing, well, that gives us a pointer. And then as a bonus, when we actually did it triggered a seizure while Amber was actually inside the scanner, which is pretty unusual as well. And so we didn't just dive straight in and do it, though. What we've got is a mock scanner. It's a pretend scanner. So it looks exactly like the scanner. It's got all the things that beep. It's the same shape, but it doesn't have any magnetic field in it. Right. And we can go in there and spend time and practice. So that's exactly what we did. We made an appointment, and Amber came in, and we brought along a bunch of different new toothbrushes and some sticks and some tape, and we spent a morning working out what the position would be right for Amber in the scanner, where she could brush her teeth. And it was really important that, it's on the right side of the mouth that activated for her, and that was where the twitching of the muscles happened with Amber's seizures. So we made sure that she brushed using her left hand, because there's a bit of hand activation as well. So we did that on the other side of the brain, and we worked out a position that worked for her. And then, having practiced it, well, when she came in on the day for the real scanner, she was able to do blocks of brushing.
And having a seizure each time?
No, the seizure only happened on the very first brushing block. So. Yeah. And one happened, and we checked Amber was okay. With Amber's seizures, they involve blanking out a little bit and jerking of the face, and it went for about 20 seconds or so. So we were able to keep recording the MRI through all of that, and Amber was able to stay still enough. You actually stopped breathing for 10 or 15 seconds during and stayed still, and it meant we were able to get really great pictures while it was happening and then do the statistics to analyse them.
Are we talking about functional MRI here? So this is the sort of more dynamic version of MRI where you're almost recording video, or is it individual scans?
This was functional MRI. So when we were talking before about getting high-res pictures of the brain, we were talking about structural MRI, which looks at what shape the brain tissue is, and that we just get a single picture. With functional MRI, it's not about what shape the brain is, it's what's the brain doing. We'd love to be able to record from brain cells, neurons directly, but we don't have that technology. It's an indirect measure. What we can measure is the MRI signal from hemoglobin and how it carries oxygen. So when a group of brain cells are being very active and doing something, doing a task or having a seizure, they're using more oxygen, and that local hemoglobin level changes, and we get a net change in the MRI signal. So like you said, it's like a video. We get a picture every second or faster, and then we watch how that signal in different parts of the brain change over time. And we knew in Amber the moment when the seizure started and the moment it stopped. So we used a bunch of statistics to look at that video of the brain to say, well, which bit of the brain is most active in this block of time.
Right, fascinating. So, Amber, you're in there, you're brushing your teeth, you have a seizure.
Having a seizure, trying to stay still, I guess. Totally wild experience.
Were there a whole lot of scientists on the other side? Just were they just cheering, because the seizure had happened exactly as you needed it to happen to help you? Yeah,
pretty wild. I guess, obviously quite, unpleasant experience being in an MRI, having a seizure. Previously, there had been a time where I had, accidentally had a seizure in an MRI, and we stopped it immediately.
Right.
It was quite scary at first, obviously, going into an MRI, voluntarily having a seizure, strapped in a machine. But, ultimately helped out so much in my treatment. Would do it again, absolutely. But, just really, really quite bizarre. The machine is so loud, and you're, in this little, metal tube. I had I had a really long toothbrush so that I could reach into the MRI. It was strapped to a stick.
Right.
So I've got this super long toothbrush trying to brush my teeth, trying to trigger a seizure, but not too much of a seizure.
Yeah. It's you say that like you have some choice.
Yeah, exactly.
Yeah. So in terms of the outcomes for you, so this has allowed the team to now do a very specific surgery on you.
Yeah,
and
absolutely.
What has that sort of resulted in? What has changed for you as a result?
Well, since the surgery, I haven't had a seizure, and that was 3.5 years ago.
At all?
At all. No, nothing.
Right.
Which is wild to me. I've gone from having multiple seizures a day, every day for about, 8 years, to now... I forget sometimes that I ever had epilepsy.
Interesting. And any changes in cognition or capability in any other way?
It's funny. Sometimes I still get, because I would get sort of auras and potentially absent seizures. Mm-hmm. And sometimes I get the feeling, I'm this feels like I'm about to have a seizure, but then I just don't have one.
Right.
And I'm oh, cool.
So when you say aura, you mean a migraine aura sort of scenario, a visual disturbance?
I don't know how to explain it. It's a feeling in my the top of my brain where I'm I don't know how to describe the feeling, but it's just I would have this specific feeling and then I would have a seizure.
Yeah, interesting. And David, when you did all this study, you mentioned you were monitoring the seizures while the teeth were being brushed. Amber suggested a number of other triggers for her seizure. How did you know, or did you not know, that this one part of the brain would also result in being curative for those other triggers?
You're right. Amber has had reflex seizures as a reflex to brushing the teeth, but she was also having spontaneous seizures as well, and like you said, one's brought on by exercise and other things. But all the seizures had the same pattern. They started with that same funny feeling at the start, then twitching of the face, and then zoning out a bit. So they were a very kind of characteristic pattern for Amber, and that's the case for a lot of people with epilepsy, that their seizure types are sort of characteristic for them, and the features of the seizure, what happens to the person, what they experience, it points to which bit of brain they're coming from.
Right.
So in Amber, the map that we found from doing the functional MRI showed the seizure was starting in the sort of central part of the brain, the bit that does primarily responsible for moving your body and for feeling sensations. So the central cortex. So other people who have their seizure focus, where the seizure starts in other parts of the brain, have different patterns of seizures that kind of reflect the function of the bit of the brain in that area. So for Amber, the risk with surgery, because of where the intervention was, it's close to the bit of brain that moves Amber's face and does sensation in the mouth. The risk was of getting some numbness in their face or weakness in the face. And I think you did have some brief weakness of the face after the surgery.
Yeah, so for about a month and a half after the surgery, it was mostly just I had a bit of a droop in the right side of my face, and things like chewing and eating were quite difficult, but that it sort of gradually got better and better as time went on until I got pretty much, I've got all movement back in my face. I don't think you'd be able to tell that I'd had surgery.
Yeah, amazing. So, David, you've identified this region of the brain, and to use Amber's comment earlier, you're not going to exactly scoop out, I love that phrase, scoop out part of the brain, but did you have to remove part of the brain, repair part of the brain? How does that work? And how do you do that when you don't have the imaging going? Because I'm assuming you can't do the surgery in the scanner.
That's right. The surgery happens in the operating theatre. Epilepsy surgery is a really well-established technique. It's great. It can be very effective and it's very safe. But no one really likes the idea of having to have a big brain operation. And for that reason, epilepsy brain surgery is really underused. Only a fraction of people who'd benefit from it are referred for the procedure, and only a small proportion of those actually take it up and go through it. So I work with lots of people who have epilepsy brain surgery, and it's a great procedure, and I wish more people would have it. I think it's got a lot to offer, but obviously people have concerns. In Amber, we were able to do a new and very precise procedure. It's called stereo EEG, and this was done at the Austin Hospital with my colleague, Associate Professor John Archer, who did the procedure with Amber. And it involves using the images we generated to very precisely map positions to put tiny wires deep into the brain, these stereo EEG electrodes. So first of all, we put them at exactly the spot where we thought in Amber the seizure was coming from, and we were able to record Amber was awake and sitting on the ward in the hospital, and we were able to see the electrical firing of that group of brain cells, and that proved that it was that spot that was driving the seizures. The treatment then is a procedure called radiofrequency ablation, and we used the wire that was already implanted in Amber's brain, and we passed a very high frequency oscillating current at radio frequency between two contacts, only a few millimetres apart, right at the spot in Amber's brain where the seizures were activating. And that causes heating of the tissue and causes a small lesion, essentially causes a small burn. And, well, Amber, you can talk about what it was like, but it happened while you're awake, and that's how we delivered the treatment. So we did that in 4 small spots, within a couple of centimetres of each other.
Did you feel that?
Yeah, you can feel it. So there's no pain receptors in the brain, so it's not painful while it happens. But it is warm.
Right. Interesting.
It kind of feels like your brain is vibrating.
Yeah. And did it change your face, your muscles? Did you notice any changes while that was happening?
I think I was mostly focused on my brain being burnt. I think in the moment I wasn't really oh, what's the left side of my face doing? So we did it in 2 separate sort of operations. I think it was twice, maybe. It wasn't 3 times. So they did a little bit while I was awake, and then I'd been sort of monitored in the hospital for a little while, and there was still sort of epileptic activities happening in my brain. So they decided to remove it a little bit more. The second time that they did the ablation was like they did the ablation and then they removed the rods from my head. So the first time was just done literally just in the chair of the hospital, which was quite crazy. And then the second one was done in the operating theatre because I also had to have the rods removed. So for the second time, I was also very heavily sedated.
Right. Yeah.
So,
That's an amazing story. Now, Heath, I wanted to ask you with regards to the functional part of the MRIs. I mean, we talk about spatial resolution a lot, so our ability to see structures and how small we can see those structures and how well defined they are from other structures and so forth. But temporal resolution here is one of the important aspects. So how much temporal resolution do we have? Like how far apart are the frames in that video we're talking about?
So currently we're down at 800 milliseconds. Is that right? Yeah. So that's another technical improvement. They used to have what was called a repetition time of 2 seconds, and that's relatively recently you can accelerate that to a resolution of just under a second.
David, when you have that sort of resolution and you have someone like Amber with seizures, are you able to see the seizure start before she experiences the seizure itself? How much is happening in the brain before it starts to impact Amber in any way?
Absolutely. In some people we can. The signal from functional MRI in the brain is really weak. It's a really weak signal. It's a less than 1% change in sort of normal levels. So normally to pick up brain activity, for example, if we wanted to map someone's language, which part in the brain uses words, which is something we commonly do with functional MRI, we get someone to do a task that activates that brain region, like reading, and we get them to do it over and over. And to detect the signal, we average across every time they did it. And that's why in Amber's toothbrushing study, we plan to do many blocks of brushing. It's like brush for 10 seconds, stop for 10 seconds, brush for 10 seconds, and then, with a plan to average over them. So when you get a seizure, it's usually a one-off deal, and the signal's pretty weak. Seizures activate brain function more strongly than normal task does. It's a pathological process, so it's a bit stronger. So detecting the brain signal is hard, but in some people we can detect seizure activity before anyone has an experience of it. It depends which bit of the brain's being activated. So there's some bits of brain that you sense immediately if they're activated. So, sensation parts of the brain or vision parts of the brain, if they're activated, you know straight away. There's other bits of the brain, the association cortex, bits of brain that are, higher order complex thinking, where their function's a bit vaguer and they're sort of flexible brain regions you can use to do different tasks with. If they're affected, the person might not have a sense that a seizure's happening for some time. So if you've got either a functional MRI or a recording electrode in that spot, you will see the seizure starting.
When we're talking about something like the surgery required for Amber, where, when you say, millimetre or sub-millimetre precision, so this is, pretty detailed stuff. Is any MRI good to go here, or is there something about the MRIs you're using at both, the Florey and at I assume Austin Health where, you have special capabilities? What's the deal there with the sort of MRI systems required?
Yeah, this sort of functional MRI is very much a research domain technology. There's very few hospitals that have functional MRI available, and it's pretty rare that it's used in clinical care outside of research. We'd love to develop it further and get it into hospitals so it can be used more widely. The scanners themselves are pretty much the same as in most hospitals. The research scanners at the Florey are, at the top of the game, but they're not too dissimilar. What really matters is having sort of the science expertise around that to do the processing, the statistics, and also the planning around how you're going to do the task. I mean, toothbrushing is a pretty unusual one, but in Amber's case, but more commonly, either finger tapping tasks to get movement, or reading tasks to map language systems would be some of the more common functional MRI tasks that we do.
Heath, we hear about this amazing capability with MRIs. I go and get regular blood tests. I even have cardio echoes, I have all these other things. Why am I not having regular MRIs? Should I be getting regular MRIs to make sure my brain is fit and healthy as I age? Is this something that we should be doing as a society? And if we're not, why aren't we?
Well, that's a good question. And MRIs are expensive, right? So that's the reason why we're not getting regular MRI scans. compared to your regular GP sort of visit. So that's one reason. I think there would be a great deal of value in imaging your brain to assess how healthy your brain is. But I think that's something that's important to bear in mind, and this is a challenge with imaging in general, not just brain imaging, is that, there are these things called incidental findings, right? And what that essentially translates to is an abnormality that you see on an image that, you might be getting scanned for some reason, but you see an abnormality on the image that's unrelated to the original reason that you're getting scanned for. And so imaging technology in general's improved a great deal. Our ability to understand what abnormalities mean hasn't quite caught up with that technology. And so an issue with imaging in general is you get what are called false positive findings, where people think that they found an abnormality on your scan that may have some consequence. You may go for surgery to get it removed. In most people, it will cause you a great deal of anxiety, the fact that you've found this abnormality, but it may not have any consequence for your overall health. People are starting to realise that just imaging people in general as a sort of screening tool may not be the best idea, because the consequences of finding something and our ability to do something about it is still limited.
Presumably we'd have to have reference scans from various points in life before you could even, without a reference scan to see changes, you couldn't really make
Absolutely, and that applies in both the individual, so having a reference scan of yourself before disease or being unwell has developed, but also having reference scans in the population of people so that you know exactly whether or not, you have deviated from the healthy population in any way.
David, obviously we've been talking about epilepsy because we have Amber here that tells this great toothbrushing story. But presumably, you have access to these facilities for other brain conditions as well. How widespread is the use of MRI in sort of other diseases, and how helpful is it for various surgeries and treatments? Yeah,
MRI scans of the brain are really a mainstay of clinical testing for neurologists and any medical team looking at brain health. So really used very widely across clinical healthcare in Australia, and I think that's only going to grow. I think technologies like CT that we talked about before have certainly got their place, but I think we're only going to see MRI become more dominant. Usually what's happening is the sort of techniques being developed in the research space, that Heath and others are working on. We need to get those to a point where they can feed into clinical work, where they can be used on a day-to-day basis. Amber's story is a very unique one, and I don't think that toothbrushing functional MRI is going to be something that's available in hospitals anytime soon. But that's very specific for Amber. What we do want to get to is a suite of technology coming from the research domain into clinical care, so that really looking at brain health and tailored to specific diseases.
Amber, what are your expectations from the future? I mean, you're one of the few people around who can say, I've had brain surgery. You've gone from having seizures multiple times a day to not at all, which is just phenomenal. What is your expectation for your life ahead? To never have seizures again? More surgeries, more MRIs?
Yeah, well, the ideal situation is just to not have a seizure ever again. So far, so good. 3.5 years is a pretty good indication that it's, probably not going to happen. At least if it does, not for a long time. Fingers crossed. I actually haven't even had an MRI for over a year. And I used to have MRIs every 6 months.
It sounds like you've lost count of how many MRIs you've had.
Yeah, I've had many, many MRIs.
Yeah, excellent. I think, Heath, the way I like to usually finish these podcasts is to ask you if a very large truck of dollars turned up to support what you're doing, what would be next? What would be the first thing you would do?
That's easy. So a population-level imaging study. We don't, generally speaking, if we do a brain MRI study, it's very targeted towards a specific disease. Our ability to really assess brain health means that we really need to know what our brains look like at the population scale. And there are initiatives that have occurred in the UK and the United States where they've done these studies that have tens of thousands, if not 100,000 people for the UK. That's been an incredibly valuable resource for research and the development of clinical tools. I think if someone came with a big truck of money, we would use that to do an Australia-wide neuroimaging study and to make that data available for researchers all around the world.
Yep. Thanks, Eve. Thanks so much for being on the podcast today.
You're welcome. It was fantastic.
David, similar question for you. The big money truck turns up. We always have hope. What would that change in terms of your clinical practice, your research? What would you do next?
Yeah, Heath's answer is a great one. Having data at a population scale makes all the difference. And the kind of care that Amber got, I'm so pleased of how it worked out for her, and I'm so pleased that we could be part of that, in a specialised research centre and hospital in Melbourne. But what I would really love is to be able to scale that to everyone in Australia who's got epilepsy. So functional MRI, it's not really available in most hospital centres, and it's certainly not available in regional areas. Having a research program that's able to deliver that kind of technology into healthcare generally across Australia, I think that'd be amazing and offer some, life-changing benefits for people with epilepsy and chances to intervene, but also in other brain conditions as well.
Yeah, amazing. Thanks so much for being on the podcast today, David.
Thanks very much, Shane.
Amber, it's been an absolute pleasure talking to you as well. I think you're one of these great examples that I suspect these two gentlemen are trying to promote, where sometimes when drug resistance is there and it doesn't help, surgery is an option that probably has worked out better for you
absolutely.
than ever being on any drug cocktails.
I don't even take any more medication I haven't taken any epilepsy medication in 3 years.
So you're functionally cured.
Yep.
Yeah, which is amazing. Thanks so much for telling us your story and for being part of the Florey's Brain Podcast.
No worries. Thank you for having me.
You've been listening to the Brain Matters podcast, brought to you by the Florey Institute of Neuroscience and Mental Health. Join us for our next episode on brain health, and if you have a particular topic you would like us to cover in the future, please drop us a comment or send a message via the email in the show notes. I'm Dr. Shane Huntington. Thank you for listening.